All right, so next up we got a couple of papers talking about what the appropriate cutoff for a D-dimer is. So, you want to kick us off, Forrest?
Nope. Okay, I will.
All right.
So I have this paper, D-dimer in patients with clinically suspected pulmonary embolism. Basically, the objective of the study was to determine whether two different methods for measuring D-dimer and ELISA versus a latex, not versus, or a latex agglutination study were useful in detecting PEs. So it was a prospective cohort study, enrolled about 221 patients. So the ELISA was shown to be nearly 100% sensitive, but maybe it wasn't clinically useful, being that it takes couple hours to get it done. The latex agglutination was not as sensitive, had a higher specificity, but was more useful in particularly our setting, the ER, when we need a result as soon as possible. But either way, they were both shown to be useful in ruling out PEs, and that's basically the long and short of it.
And what was the level for those?
The ELISA was 300, I believe, and the latex agglutination was 500.
All right. So next up, we're going to have Brave Mario here to discuss an adjustment to that strategy of an isolated.
All right. I'm going to be reviewing the age-adjusted D-dimer cutoff level to rule out pulmonary embolism. The study has a pretty cool name, the ADJUST-PE study. The bottom line up front is that the combination of pretest clinical probability with an age-adjusted D-dimer cutoff was associated with a larger number of patients in whom PE could be considerably ruled out with a low likelihood of subsequent clinical venous thromboembolism. I mean, everyone here has read the paper. So the keystone of many things in emergency medicine, including assessment and testing for a PE, is the pretest clinical probability. Some people might refer to that as clinical gestalt. In the ADJUST-PE study, they used either a revised Geneva score or a two-level Wells score. These use, either subjective and objective parameters to risk stratify patients into a low, medium, or moderate or high risk for PE. My view of these scores is pretty simple. They look pretty good on a chart, and they're probably good for a family practitioner that's moonlighting out in a rural ED somewhere. But if I'm even thinking about pulling out a Geneva score or a Wells score, I'm probably going to go ahead and get a definitive study on that patient, be it a CTPA or a VQ scan. If the differential for PE is so low on my list, but a patient has one or two vitals that are abnormal that I can't otherwise explain, or something in physical exam is bothering me, then I think using the age-adjusted D-dimer is a perfect tool to add to the chart. And the data, both retrospectively and prospectively, supports this argument. The failure rate in the ADJUST-PE study was 0.3%. And the CTA, which is considered the gold standard for diagnosing a PE, has a failure rate of 3%. So this tool has a much lower failure rate than the gold standard, which is the CTA. There's very few absolutes in life, much less so in medicine. Using the ADJUST-PE study, it has the lower failure rate than a CTA. And the bottom line is that if you're in medicine long enough, you're going to miss things. And that's okay. If you're practicing emergency medicine, just as another reasonable emergency medicine physician would practice with the same data that you have, your chart's going to stand scrutiny in any court.
now to kick it up a little bit, I want you to each try to make the case of whether we should use a static cutoff, which is going to be 500 for most assays here, versus an age adjustment. So far as tell us why we should not be ready to use this age adjusted.
I'd be happy to, Dr. McCall. Not too surprising. I'm very pragmatic. I like to keep things simple. We have proven studies that show the utility in using a cutoff of 500. But if we continue to push the limits as the adjust wants us to do, we're going to start missing things. So I think the focus should be more on Gestalt as opposed to, like I said, pushing the limits of these tests. However, that is a subjective view. Objectively, just looking at the adjust study, number one, it was conducted in Europe, and they are inherently untrustworthy over there. Number two, this was not a randomized controls or a randomized clinical study. Number three, and correct me if I'm wrong, but it seems like they used several different methods. They used a Geneva, a Wells, and I read somewhere that they used up to like 6 different commercial D-dimer tests. So in no way did they perform a uniform test people uniformly across the board.
All right.
Well, my colleague here brings up simplicity. I don't think that multiplying somebody's age, if they're above 50 times 10, is very difficult. I mean, it's just adding a 0, really. But to get to the point, if you're using 500, what are you going to do if it comes back 499? Are you going to not CT that person, or what if it comes back as 501? Are you going to CT that person? Are you going to anticoagulate that person? Are you going to withhold treatment on somebody just because the number is right below a fixed line? And the other thing is, and I kind of stated it before, in medicine you're going to miss things. The PE is one of those diagnoses that even with our best imaging modalities, it still gets missed. But what we're really looking for is clinically significant PEs. I bet you there's a lot of people walking around right now that have tiny subsegmental PEs that don't really matter. But the clinically significant PEs are the ones that do. The failure rate, as I said before, with the Adjust PE study was pretty darn low. It was 0.3%. And it's going to save time, your time in the emergency room, the hospital's resources, and potentially be saving a lot of patients' kidneys from a huge load of contrast that they don't really need to get just because they have a number that's 500 or 501 versus somebody that's 75 years old whose D-dimer walking around is 500. That's my point on that.
Guys. So the question is it ready for prime time to use an age-adjusted D-dimer cutoff, or should we stick with the traditional 500? So let's hear a round of applause for those that think that we should have the standard 500 flat without age adjustment. Okay. You know what? We're not going to ask the second part. We're just, so let's discuss. Let's give a round of applause for both these guys. Actually, a very good job for doing this. This is probably the most unbalanced of the 3 journal article things because I think this is already creeping into practice a good bit. And I'm probably in the minority of attendings that don't always scan, even if they're higher. I do age adjust. I'll talk with Brad and find out from the lab exactly if it correlates to this exactly. But I have chosen not to scan people with positive dimers.
So one interesting comment about that is how they decide those lab values is not exactly purely scientific as well. And I just recently we just changed our folate level norms for the whole institution. And we basically picked a number based on a little bit of this, a little bit of that, and said, well, this doesn't really represent malnutrition, but this does. It's very interesting that it's not as hard science-based as you would think it is. So, that value, who knows, if you really chase that to ground where that value came from, you may find out that it doesn't have a great foundation.
So a lot of times what they do is they'll take the package insert, the range that's on the package insert, and say, okay, this is what we're shooting for. And then what they'll do is they'll have whatever leftover serum or blood, whatever sample they're using, either serum, plasma, or whole blood, and they'll run 1,000 of them through the machine, and they'll come out with an average. They'll get a median, and they'll get a high and a low, and then they make their own reference range. So our reference range is going to be different than some reference range in California, though they're based on the same test and the same methodology. So that's part of how they get that. And then they throw out highs and lows and fudge factors and this and that and the other.
This is kind of instructive for the residents. Once you're out on your own and practicing, you're going to be a lot more conservative than the gunslinging selves that you are now when it's just you. And so it's very easy to take a look at a paper like the Age of Dust and say, you know what, I'd look at this guy with a D-dimer of 690 and send him home because he's 70. It's really easy to do until it's just you and you're really worried about missing something. And you'll find that you're a little bit more conservative when you first get out. So I think
that's a good point. I was sitting here reading the two papers. I was trying to come up with a good argument. I'm completely on that side as with everybody else. I had that thought while I was reading it. Well, I can talk a big game now, but in 2 years when I'm out doing my thing, am I really gonna?
it's hard. And so I think that Forrest did a pretty good job. Mario, your job was mediocre at best. But I kid. You guys both did great. I think that it seems one-sided with the resident voting, but then it's instructive that the majority of the attendings in this room wouldn't age adjust, even without the question of the labs, because it's hard to look at like a positive troponin that's technically positive and consider, not acting on it. That's really difficult. It's kind of baked into us. If you've got a critical value, you should do something with it. And that's hard to overcome, even if there's decent literature that tells you that you ought to. That's not easy, and it's legally a little bit riskier because it's so easy for a lawyer to say, like, what color were these letters in your thing? Was that a red number? Oh, I hear the red numbers are bad, and it's hard. I strongly encourage you that if you want to use an age adjusted and you're out in your own private practice thing later on, that almost every EMR can timestamp what you type in. If you say, look, I'm planning on using an age adjusted for this guy, and so the cutoff is going to be 650 for him because he's 65. If you have that timestamp before the dimer comes back positive, it's going to make you look a lot better because it shows that even before the test came by, you didn't try to explain it away with wizardry and, I don't really want to spin this guy anyway. I'm just going to make something up. It looks a lot better to show that you knew before the test came back that was your cutoff. And it's a really quick thing just to type in. I'm using age adjusted 650 or less, I'll scan, otherwise not. And it shows what you were thinking.